Our next speaker is Dr. Barbara Blair, who's an infectious disease specialist at the Mass General Hospital. She's the director of the Complex Outpatient and Antimicrobial Therapy Program, and she'll be talking to us today about infection in transplant patients.
Good afternoon. Thank you to the program organizers for inviting me. As I was introduced, I'm here at MGH, been in Boston forever. I have no disclosures, and I'm going to try to talk to you about a huge topic, and won't get through everything, but I'm going to hit some salient points, and specifically the topics that are listed on this slide. So when I approach a patient with a concern for infectious disease after transplant, I try to think back to the pre-transplant evaluation and whether or not there was any latent infections that were identified. And that actually can be very helpful in knowing if they were treated or if they still may be an issue. Furthermore, when I think about an individual who is coming in with a concern for infection, I try to think of their net state of immunosuppression, which involves actually who the patient is with what comorbidities, how much immune suppression they're on, and how long they've been on that, as it impacts where they are at this time. And so I wanted to talk about the host themselves and donors by jumping into two cases that I thought would be illustrative. The first one is a 50-year-old woman who had end-stage renal disease and due to FSGS, who was originally from Southeast Asia and got treated for her latent tuberculosis before her transplant, and then received a deceased donor kidney with alemtuzumab induction and was receiving standard IS with MMF, GROW, and PRED, as well as standard opportunistic infection prophylaxis. Her course was complicated by delayed graft function, and she had been discharged, but about 4 weeks after transplant, she started having fevers and night sweats. Imaging was performed that showed some lung nodules and fluid collections around her allograft, and a transplant biopsy looked like neutrophils without rejection and negative cultures. So I did throw a question in about what you thought the yet to be identified infection of this patient is most likely to be. Cool. All right, well, I'm going to keep going because it bleeds into this next case, which is very similar. So a 70-year-old gentleman who's US born with no travel history, with high blood pressure and end-stage renal disease, with a negative pre-transplant ID evaluation, who also had a deceased donor kidney transplant, got ATG induction followed by standard TACRO, MMF, and PRED immune suppression with standard infection prophylaxis. He presents 5 weeks after transplant with persistent fevers, and he has cross-sectional imaging that showed a normal chest CT, but with rim-enhancing fluid collection around his transplanted kidney. An aspiration of the fluid collection is performed. And before we tell you what it is, then same question for this patient, given their similarity, what you think the most likely infection for this patient would be. Great. You guys are super smart already, so I'm just going to jump in and tell you that all of you are thinking about this the right way, because really there's no right answer here. And the most likely may not necessarily apply here. And let's kind of discuss. And so the cases I presented were based on my conversation with a nephrologist about what would be the most kind of salient or important things to discuss for infections if you needed to have a half an hour talk about infections for kidney transplant. And one of the things he suggested was tuberculosis. And so we're going to talk about screening for latent tuberculosis. But for the first case, you all were very smart in identifying the history of latent TB and thinking about that maybe that person had reactivated their latent tuberculosis in a short period of time after transplant. And I'll go on to show you a slide about when latent infections usually recur or kind of come out, but in that 4 to 5 week range is a little bit too soon. So these two cases actually came from this case report of 3 recipients from the same donor being diagnosed with disseminated TB. Both the kidney recipients and the liver recipient got disseminated TB. And you could have considered, as you guys did, that both cases might have been around related to surgical complications, although that seemed a little bit late because it was moving towards like the 4 to 6 week mark. And again, a little bit too early for reactivation of tuberculosis for latent infection. And then the second patient really had no identifiable risk factors. So astutely, what the providers in that case did, which kind of helped seal the case for everyone, was that they reached out to the OPO about this atypical case and then got information that there were recipients at other institutions that were experiencing similar things, and that really cinched the diagnosis. So I show you this slide, and probably many of you have seen it before, but this is from Jay Fishman's Sentinel article about the timeline of common post-transplant infections. Just to highlight, so kind of here, fungus, bacteria, and parasites, and early kind of within the first 4 weeks, it's all about kind of the hospitalization, the anatomic leaks, the surgical things. So our patients were a little bit out from this. Really kind of where they were, you could have thought about some of the fungal infections, although neither of them had risk factors. And that's where kind of thinking about the host and kind of what they've experienced and where they've been and what immunosuppression before their transplant occurred. And then as far as reactivation of latent infections, that, it starts about 9 to 12 months after transplant in most cases, if you're going to actually get tuberculosis from a latent infection. And so I know that there is a talk either later or there already was a talk out kind of the pre-transplant evaluation, so I won't belabor it too much, but it is helpful to have, I think, for an infection person to see them to modify any risks by vaccination and then really identify any latent infections before. And particularly, I'm going to talk about tuberculosis screening because of my colleagues' interest in that. And then I think it can be particularly challenging, but also something that as a nephrologist, you are very used to dealing with in your end-stage renal patients. I'm not going to focus on kind of what typical people might focus on in infections after transplant, such as HIV and the hepatitis, because now there's excellent protocols around kind of screening for recipients and donors that have really been amazing at sort of making testing easier, standardized, and protocols around that. So universal screening, it happens for tuberculosis in most centers, and it's important not just to take one piece of screening, but think of a holistic approach. And really, so reactivation TB happens a lot. About 10% of those with latent TB will develop active T, and in a transplant population, it's about 25% higher. And then if you look at developed countries, more often it's lungs, then kidney, pancreas, then liver, and then lowest actually is kidney. And screening, most of us now, I think, do interferon gamma release assays, But I note that even in the setting of negative testing, because as you know, with end-stage renal disease, your patients may, over time, by the time they're presenting for their transplant evaluation, have relative immune suppression and may have a false negative or indeterminate interferon gamma release. And so if they've ever had a positive TST or IGRA, they should be considered for treatment. Certainly an X-ray, if someone has come from a high-risk area, has high-risk factors, even the negative TST or IGRA, if they have calcific disease on chest X-ray, then treatment should be considered. And then in other parts of the world, not the United States, but in other endemic areas, many centers would actually prophylax universally after transplant. And so that's tuberculosis. Let's talk about other infections kind of around donors and the early post-transplant period. So it's possible that your kidney recipient could get a kidney from a bacteremic donor. And most often that's fine because our perioperative antibiotics actually address that. And as long as those donors have received appropriate antimicrobials, things go relatively well. And being seen by infectious diseases afterwards can kind of help with the duration post-operatively if necessary. If for other non-bacteremic donors, for the kidney transplant in particular, if there's UTI at the time in the donor prior to transplant or bacteria, that should be considered because you may want to treat that after transplant. And then the area that I think is a little bit tricky and should be carefully thought of is recipients with organs from donors with multi-drug resistant gram-negative bacilli. So knowing that at the time of organ procurement / donation, implantation will allow for perioperative antimicrobials to maybe be targeted, which may not have been in the routine prophylaxis. And then there has to be communication between centers. And then lastly, candidemia. Unless it's well-controlled pre-transplant, anyone with uncomplicated candida infection that's been treated and cleared, that organ could still be procured and used, but anyone without, it can get tricky. So that sums up those infections. I'd like to talk about CMV a little bit. And in this case, if they bring up the audience response questions, but basically, this is a 42-year-old woman who had her living unrelated kidney in 2015. She was CMV low risk, EBV moderate risk, had noro in the past. Her brother recently had mono. She develops fatigue, myalgias, fever, and then diarrhea. She has a leukopenia, thrombocytopenia, AKI, transaminitis, and her norovirus PCR is positive. So what do you think is going on here? And I'm just going to skip, well, maybe I'll give you a couple seconds, maybe, because I gave away what the topic of this section is. So it's actually acute CMV with norovirus. You all were getting it, infection or colonization. And I love this case because that person's brother didn't have EBV mono. They probably had CMV mono. And even though a lot of CMV that we think about in transplant is preventing the reactivation early on post-transplant, up to 25% of people get late CMV. And then you can, if you're CMV low risk, actually get de novo CMV infection at any point after your transplant. So how we think a lot about this troll of transplantation CMV. How do we take care of this? Well, you can prophylax, and many people do. Actually, many centers universally prophylax. And this table is taken from the international guidelines. Nowadays, we either prophylax with valganciclovir or termavir. Both a universal prophylaxis regimen and a preemptive regimen work equally as well. If you can get the results, there's plus and minuses to each. And then valganciclovir and letermovir work as well, and we'll talk a little bit about that. So when thinking about how we decided about 6 months for high-risk CMV prevention prophylaxis, it came from this study, the IMPACT trial, published in 2010. It looked at placebo versus, well, it looked at 100 days, so 3 months versus 6 months, and the second part of the other 3 months in the 3-month group was placebo. So you either got 3 months of Valsite plus 3 months of placebo, or 6 months of Valsite, dosed according to your renal function. And then the outcome was looking at CMVs in the first year post-transplant. And what you can see here is that 6 months of prophylaxis had a 20% lower risk overall of CMV over the first year. But what you can still see, despite this, if we go out, this is about 6 months here, that you still have CMV presenting late in the first year. As all of you probably know in this trial, that CMV prophylaxis can decrease prevention CMV while you're on the prophylaxis, but it doesn't take away the risk after stop prophylaxis. And we'll talk a little bit about what studies are being done to see if we can predict who those people will be. And so then this is the data from letermovir. Letermovir, as you guys know, inhibits the CMV DNA terminase complex, the UL56 subunit. And this trial looked at whether or not you gave letermovir or valganciclovir. Why would you want to use letermovir? Because it doesn't have the hematologic toxicities as valganciclovir did. It was first studied in the stem cell transplant population, and now has an FDA indication for high risk kidney or CMV kidney transplant recipients. The one caveat of it is that it doesn't protect against herpes viruses, so you do need to give an additional antiviral to prophylax against herpes viruses. Then this is the big question. There is, I just told you, about 15 to 30% of people who are CMV high risk who develop CMV disease after prophylaxis is stopped. And we really don't have a good way of predicting who these people are. So there've been assays developed looking at CMV cell-mediated immunity. And people have studied here, the same group that put out the letermovir information about whether or not you could look at cell-mediated immunity and see if it was present or absent at the stop or kind of during CMV prophylaxis and thereafter, and whether or not it predicted who's going to actually get CMV. So what they found in the two arms, they gave one group letermovir, one group, these are all high-risk patients, valganciclovir. In all of them, the CMV cell-mediated immunity increased over time post-transplant. Additionally, the amount of immunity was similar. So one drug didn't give you more immunity or less immunity or kind of have a negative impact on it. If you did have CMV immunity, most likely at some point during that year, you did actually have breakthrough CMV event. And then the most disappointing part of the study was that even if you had the negative CMV cell-mediated immunity at 28 weeks, that did not predict that you would then go on to have CMV disease. So unfortunately, it was a negative study, and most of the people who didn't have immunity still didn't go on to get CMV disease. So we're still going to be looking to how to predict who will get it a little bit better than what we have right now. So I think I'm just gonna talk a little bit about resistance because it can happen when you're on. So if you can't talk about prophylaxis without talking about valganciclovir or antiviral resistance, which happens if you are suboptimally dosed, which can happen in renal dysfunction, or if people unfortunately decrease the Valsite or Valgan dosing because of leukopenia. And then in the past, we've only had parenteral treatment or kind of really intolerable medications. So now we have maribavir, which is less toxic and it's oral. It targets the UL97. This is the Sentinel study quoted here that shows that it was as good as investigator-associated, actually better than standard of care, and that the only kind of downsides are that there's no clinical efficacy against other herpes viruses, just like letermovir. It does cause people to have a terrible taste. One of my patients told me it's like sucking on quarters. You have to adjust the tacro. If you have retinitis or any concern for CNS disease, it's a bad drug. And then some people don't like to use it at very high virus levels because of the risk of resistance. So there have been some treatment failures. And then no talk on infections in kidney transplant recipients is over unless you talk about urinary tract infections. And I realized in preparing for this, my slides give away so that we're not going to do the antibiotic or the audience response question. But this is a patient I saw who had a congenital bladder dysfunction, which was complicated by CKD. He underwent a colonic bladder augmentation as a child. With ureter replantation, and then had a living unrelated kidney transplant in 2019. I met him when he was actually 18 months after transplant with lots of sepsis episodes of transplant pyelo due to E. coli. He had excellent graft function. We found urinary retention. We started him on CIC, and then we started rotating antimicrobials to prevent UTIs. He was actually able to come off antimicrobials after he had gastric bypass surgery, lost a significant amount of weight, and was now euglycemic. And then all of a sudden, he started having recurrent urinary tract infections again. And so I'm going to skip because this is really the issue here was what's going on. Actually, there's a new anatomic issue. So we had him go and get seen by his urology team. They did a cysto and they found a mucinous adenocarcinoma in the colonic bladder augmentation. So I give this story just to, if something was working and then it's weird, don't forget these are immunocompromised people who can get malignancies and weird things can happen. So still kind of systematically going through an approach to them. It did drive me crazy for a while. And then this case I love because it's just a typical postmenopausal woman with UTI, except she has a kidney pancreas transplant. So lovely lady who has had diabetes since the age of 5 and underwent a kidney transplant first in 2018 and then a pancreas transplant. She has significant PAD and diabetic feet, and then actually suffered a couple strokes. So prior to their strokes, she was actually on hormone replacement, and actually that did great for her as far as her not having urinary tract infections until she needed to stop the hormone replacement because of her CVA risk. And then graft functions great, no diabetes. Over 9 months, she gets 4 episodes of cystitis with various bacteria. And so I wanted to ask, and since I actually can tell now that I do have some time, I'm going to let this audience response question go. What is the best management of this patient? Yay. Great. I see responses in everything except the increased hydration, which is all right. So the trick here, my tricky questions that I always ask is I say best, and maybe that's your definition of best. I think all of these are not incorrect and can be correct in the right setting. I do think any postmenopausal woman with recurrent urinary tract infection should be evaluated for vaginal estrogens. And then antibiotic suppression works always. It just has different downsides. There was a study about increased hydration in non-kidney transplant I don't think it hurts people. I don't know that it's proven, 100% efficacious. And then daily methenamine we're going to talk about. And so why do I bring this up at all? Because of this meta-analysis and kind of all of y'all's experience is that urinary tract infections in kidney transplant recipients is super common. And then recurrent urinary tract infections in kidney transplant recipients is super common. And so I love this paper from the New England Journal in 1993, and I love showing this Kaplan-Meier curve that you probably all know. And while this study was not performed in transplant recipients, I do think that its findings can be extrapolated to transplant recipients. And so when vaginal estrogens were given to women with atrophic vaginitis, with recurrent urinary tract infection, there was a threefold decrease in recurrent UTIs in the estradiol group as compared to placebo. And so sometimes that alone doesn't work. And what about what else? So methenamine, I think people in the past have been worried to use it, but this retrospective study out of Northwestern by Mike Eisen and his group actually looked at their center and looked at their use of methenamine. And the real important parts of this are that are kind of surrounded in red. UTI actually rate decreased when they gave their transplant recipients methenamine. They needed fewer people ultimately ended up on antibiotic suppression because they were using methenamine and subsequently, and then their rate of hospitalizations actually decreased with this, which is huge. And then if I were a transplant nephrologist, I would be like, that's fine, Barbara, but what about my graft function? Graft function stayed the same, no change in creatinine. So really for this gigantic topic in 30 minutes, I want to take home that infections are unfortunately not uncommon in transplant recipients. Donor-derived infections are rare, but the pre-transplant evaluation and screening for latent infections can help you. CMV is the trial of transplant prophylaxis works. And then UTIs are very common. Recurrent UTIs happen and prevention strategies work, but there's no one size fits all. And I will be at the question and answer period afterwards to answer any questions. And thank you all for your attention and time.
Thank you very much. That was great.